So without further ado, let's get started with our first talk on neurodiversity and psychotherapy from Allison Haynes. So Allison is an autistic and ADHD psychologist who was driven to study psychology when she became frustrated with the lack of support for her autistic children. She's been a practicing clinician in private practice for 10 years and now owns a successful neurodiverse affirmative therapy clinic in Brisbane, Australia. Her clinic, Left of Centre Therapies, has been nominated for multiple awards, with all clinicians either being neurodiverse themselves or closely related to an ND family member. Left of Centre is an educational practice where provisional psychologists obtain top quality training and support in how to practice in a neurodiverse affirmative way. Left of Centre works hard to make each session a safe space for ND individuals to be able to unmask and explore their authentic selves. In her spare time, Allison is writing her autobiography about raising autistic boys while coming to the realization that she herself is autistic. You can learn more about her work at www.allisonhainespsychology.com.au. And Alice, whenever you're ready, let's just get started. I'm really excited about this talk and best of luck.
Thank you. Well, hi everybody. I'm seeing everybody in the chat to say hello. Just a really quick correction. My website is actually www.loctherapies.com, but check us out over there. So we may as well get going. So the topic today is about neurodiversity in psychotherapy. And I'm actually going to be covering a lot about what it is to be neurodiverse affirmative as a practitioner. And I will also talk a little bit about how it looks in session. We're going to talk about some of the terminology because this space is really, really new. It's only really come up and gaining traction in the last, even 12 months. So there's a lot of this terminology that hangs around that people like us who have been in that space from when it happened, when it started rolling, we throw these terms around, but we realise that, the general public and other practitioners don't really know what we're talking about. So we'll go through some of that. We'll talk about why there has been a shift in the paradigm. Why are we moving away from early intervention and things like applied behaviour analysis, ABA, and towards this neurodiverse affirmative practice as well. So that's sort of the theory side of it. And then we'll move into more of the practice. What does it look like in session? I don't have any written out examples, but I'll talk through some of the examples from my own experience of sitting with clients and how that looks. And we'll also look at some things like what does a positive behaviour support plan look when it's neurodiverse affirmative. So without much ado, let us get moving. So who am I? What gives me the authority to speak on this stuff? So I trained about 10 years ago as an educational developmental psychologist in Australia. So that's a 6-year course of study with a full master's. And at the same time, I was actually raising my 2 boys. Now, one has a formal diagnosis of autism and the other one we generally figure is autistic. Is pretty much there. Both of them also have ADHD. They also have post-traumatic stress disorder from the experience of having to live in a neurotypical world. And that's something that I'll go into later as well. About sort of 5 or 6 years ago, I came to the realization that, I'm probably autistic too. And it was one of those moments where I went, so now I know why I didn't feel comfortable in this world. Now I know why I always felt like I didn't quite know what was going on around me. I didn't quite know why other people got the social stuff. Why I love the academics and other people were going, you like school? What's going on there? Last year I decided to actually formalise that. And I went and had myself assessed. And surprise, surprise, I also came out with an ADHD diagnosis. So I'm now diagnosed autistic and ADHD. I also have a little bit of trauma there myself, again, from living in a neurotypical world. So my experience when I was trying to support my son when he was younger was that one, there was no services around, very long wait lists. We didn't really know exactly what was needed to make him feel like he was an okay kid. Excuse me. There was lots of talk around early intervention and lots of talk around social skills and lots of talk around anger management. And I went along with that for a long time. And I think we kept hoping for this amazing, intelligent, quirky child to become normal, to become neurotypical. But I could see that the pain, yeah, he could mask, he could behave, but it wasn't him. It wasn't comfortable for him. So we finally got into some psychology and we started to do some emotion regulation, and that seemed to be a little more successful. And at the time I sat in on the psych session, and about 2 sessions in I went, that's what I want to do. That's it. That's where I'm going. But I want to create something where autistics feel okay, where it's okay to be who they are. 14 years later, we opened Left of Centre. So I went back to uni. I studied psych. I then worked in private practice for about 8 years. And then I finally had the guts to go, no, it's time to open the business. And we have taken off. We started not quite 2 years ago with 3 people. And we now have 22 employees. And we have a wait list a mile long. And each and every one of our employees is either neurodivergent or has a family member that is. So we're working from very much a lived experience perspective. And so far, so good. I love my team. I love my workplace. It is the most beautiful place to work in. And if there's anybody who wants to come and work with me in Australia and has that, please come and chat to me because we are desperate. So as it also says on the slide, I'm also a board-approved supervisor of trainee psychologists. In Australia, you have to have been registered for 2 to 3 years before you can supervise psychs. And the provisional psychologist program is that program where you go out and you're in front of clients and you practice and you supervise. So I actually have about 9 or 10 provisionals that I supervise and a number of other fully registered psychs that I guide around the neurodiverse affirmative stuff. I lecture every year at one of the universities on the autism stuff for the Masters of Psychology students. And I've also published a little bit about my own personal story, and I'm working on a couple of other books as well. So just a little bit busy. Alrighty, so let's move in. So let's talk a little bit about this terminology stuff. And I'll go through each of these separately, so don't panic. So we'll talk about the difference between the word neurodiverse and neurodivergent. And then I'll also talk about this idea of a spectrum not being a line, and that will come into why this needs versus functioning debate is out in there at the moment. Then I actually really want to talk about the social disability model, and I think you guys will find this particularly interesting, and it might have some aha moments for you. I hope they do. We'll talk about the language that we use with neurodivergent people, and then a little bit about masking, and then finally ableism, which is the discrimination that happens to our neurokin. All right, so neurodiverse versus neurodivergent. A lot of people get these mixed up, and it's really understandable. It's ND, we're going to get this mixed up. So when we talk about neurodiversity, we're talking about the whole spectrum of everybody, right from neurotypical, normal, average, whatever you want to call that, right up to the, to anybody who has a diagnosis of a neurodivergence. So you can see this visual that I have here in that first slide there. It says diversity is a diverse group of shapes. And you can see there's like 5 or 6 circles, and then there's a square, and there's a triangle and a rectangle. And the circles in that would be considered neurotypical because they're the most common. But all of those shapes together are neurodiverse. If you're neurodivergent, you're one of those rare shapes. So you're the minority. And so being neurodivergent, by definition, means you're part of the minority. So it's really important to remember that. So as an individual, you can't actually be neurodiverse because neurodiverse refers to a group. A group is diverse. But you can be neurodivergent, which means that you're part of the minority group. So in the next one with all the triangles, which is a bit like my family, there's a family of triangles. They're all divergent from the majority, the neurotypical, which is circles. But they're not diverse because they're all triangles. So within the family group, they're actually all the same. So in the next one, that the rectangle is divergent. They're from the average, from the circle, which is neurotypical, but they can't be diverse because there's only one shape. There's no group, and I've mentioned that before. So if we look on the bottom line there, the family is diverse, and there's 2 divergent members and a neurotypical member. So, and this is where we start butting up against some of the problems, because our society at the moment is built for neurotypicals. And so neurodivergent people like myself and some of the other members that I've seen join the talk today actually can't access society fully because there are barriers to the way we live our lives. And previous to this, this was seen as the disability. So trying to fit in, what we're saying by neurodiverse affirmativeness is we're trying to create a society where everybody can access all aspects of society in an equitable manner. So I hope that makes a little bit more sense to you guys. So there has actually been quite a bit of chat and a bit of discussion around what is considered neurodivergent. So when we talk about neurodivergence, we are actually mentioning that the term neurodivergent was actually raised back in the 80s, I think. And what the original author of that, or the person who coined the term, meant was that they meant any person who has a neurological difference, so a brain difference, to the neurotypical. Since then, the word has been used in a number of different ways, and at the moment, the conditions that are listed here, so dyspraxia, dyslexia, which are specific learning disabilities now under the DSM-5, autism spectrum disorders, speech and language, ADHD, and dyscalculia. I'll also include gender diversity here, are generally agreed on by everybody that these are neurodivergent. Some people will also want to include things like OCD, bipolar, severe trauma, childhood trauma, schizophrenia, even maybe anxiety and depression, because we can measure that if somebody's experiencing those conditions, there is a brain difference, there's a brain change. So where we're actually going to land on that, that one's still up for debate. But with the ones that are shown on the screen here are pretty much agreed on by everybody. So when we talk about neurodivergent, mainly what we're talking about is what you're born with. And the difference between these conditions and like the OCD, trauma, bipolar, etc., they're sort of considered that they happen to you later on. They're like adverse events that then change the brain. So I'll let you decide where you want to stand on that one. I actually don't have a lot of stake in it either way, because personally, to me, somebody walks in the room and they're a person. At the end of the day, they're a person, and I want to know who they are as a person. These labels that we have, or these neurodivergent conditions, can give a framework as to where somebody might sit. But beyond that very loose framework, we can't really make many more assumptions. And then it's up to us as people, as clinicians and as decent humans, to actually just sit with that person and get to know them. So what goes on that slide, really, up to you. The other thing that I'd really like to go over is the misconception over the last few decades that the autism spectrum, or even any neurodivergent spectrum, I should say, it's not linear, it's not a line. So the visual I have here is to do with autism, and autism's sort of my main gig. But please be aware, when I talk about autism, I actually am referring to all neurodivergence. I might slip into a bit of autism-specific language. So it used to be seen, and especially under the old DSM-4, that we used to have PDD-NOS, which is pervasive developmental disorder not otherwise specified. In other words, the longest name was ever heard for, we're really not quite sure what's going on. But then we'd move up to the next point, which was Asperger's disorder, and then autistic disorder. And it was sort of understood that, you're moving up the line to slowly more severe. The DSM-5 broke that down. We now talk about autism spectrum disorder level 1, level 2, and level 3. And the levels are indicative of the level of support and accommodations that is needed for that individual to access society in an equitable manner. But again, that's still sort of assuming that there's this, you're high functioning, you can do this, you don't need a lot of support. Moving up to level 2, where things are starting to get a bit more difficult, and you might need some accommodations and support. To level 3, which might include intellectual disability, it might include non-speaking. But again, it's not really encapsulating what is actually going on in neurodivergence. So the graphic I have here is more around recognizing that everybody who is considered neurodivergent actually have a series of strengths and a series of differences away from neurotypical, but different to the next person who is neurodivergent. So you can see on this sort of circular pie chart that's here, we've got for this hypothetical individual, that they've got pretty good social skills, they're not too fixated on things, they like their routine, they might engage in some sensory seeking, but not as much. Their executive function is quite challenging. Their perception of the world is, maybe a bit more left of centre, hence the name of my clinic. But the next person that you might see might actually be have a lot of challenges with socialising in a neurotypical manner. They might get very fixated and very interested on special topics and do what we call this info dump. They might be okay with coping with unexpected changes in their routine. So it's about really recognising that when you say, I'm high functioning, that's actually a misnomer, and it's actually not true. Because what is high functioning? High functioning how? High functioning where? High functioning when? And I talk about this a lot, especially when I lecture. So I could say to you now, apart from my nerves, which I'm sure you've already picked up on, is that I'm in a professional environment at the moment. I'm talking about stuff that I'm passionate about, stuff that I feel that I know a little bit about. I have taken my medication, I've written my slides, I've prepared everything. I'm high functioning at the moment. Hopefully I'm not speaking too fast. Hopefully I'm making sense. Hopefully I'm interesting you guys out there. But when I go home at the end of the day, or at the end of this couple of hours that you've got with me, I'll completely collapse with exhaustion. And I may have to sleep a lot of tomorrow. I struggle to get a load of washing done and hung out all within one day. I cannot keep my house clean. So in the home environment, where I have to juggle a lot of household tasks and try and recover from the exhaustion of running a business, I'm low functioning. I'm very low functioning. I have the ability to socialize quite well in a neurotypical situation. I have no ability to remember a request that somebody tells me verbally. My poor old team, they know now if they want Allison to do something, email her. And if she hasn't done it within 3 days, email her again. And I give them permission to nag me, because if it hasn't done within a couple of days, it's dropped out of my head. It's gone. So the accommodations that I've asked for there is that any requests are in written form. So, and that's, I think, a really interesting example of how you can't just say, oh, look, I'm a high functioning autistic. At the moment, I might seem pretty high functioning, sure, great. Not tomorrow when I'm recovering. I will be almost non-functional. So it's really important that we actually start to drop this functioning label, because it puts people into categories, and it both at the same time denies people who can appear to be high functioning the actual supports that they need, as well as denying people who are considered low functioning the celebration of the competence and the unique talents and strengths and value they bring to our society. So it actually harms everybody who's neurodivergent. So what we talk about now, or what I am encouraging, especially my clinic, to talk about now, is levels of required support. And each of those levels of support need to be personalised, and they need to be detailed, and they need to be what we call operationalised. How is that actually going to look in day-to-day life? So it's about, again, sitting down, getting to know the person. So for me, levels of support would mean having a housekeeper in, which I'm still yet to organise because it's not written down and it's fallen off my executive function list. But anyway, don't need a hell of a lot of support at work, except if you want me to do something, email it to me. Don't ask me verbally. Yet somebody else might be really, really good with their verbal memory, might have the house immaculately clean because that gives them a sense of safety and a sense of calmness, but can't manage regular employment. So, you know, it's just that environmental functioning. So let us move on. Where's my clicky thing? There it is. So, oh, and the last point there, and this is a bit of a personal one, and I'm sure there's going to be some people who don't agree with that, and it isn't true in every case, just like everything. Often, sometimes I see levels as indicative of the amount of masking. So I might be, say, considered level 1. To me, all that means is that I mask really well and I get to pretend to be neurotypical quite well. But underneath, in my brain, neurologically, I'm as autistic as I don't know, am I allowed to swear? I better not. But you know where I'm going for. All right, so this is another huge area that I get quite passionate about. I hope I'm not getting too passionate. Historically, we have seen neurodivergence as a disability, and there's a whole argument around whether disability is a stigmatized and negative term or not, and I don't think I have time or capacity to go into that argument here. I'd love to, but we've sort of got to keep ticking along. However, with that term disability comes the assumption and the inherent idea that the person is internally disabled. In other words, that because somebody is ADHD or, or if they have a speech and language disorder, and there I've used the word disorder again, it makes them wrong, makes them faulty, and makes them somehow bad or broken. What the neurodiverse affirmative movement is actually saying is that we're not wrong, we're not bad, we're not broken, we're not less, we're just different. And if we had a society that removed the barriers to access, we could actually show a true value. So you can see in this table, this visual here, that in the medical model, the child is seen as faulty, or the person is seen as faulty. In the social model, the person is actually valued, and it's about valuing what they do bring to the table. And with the medical model, we talk about diagnoses, we talk about labels, we talk about impairment, we talk about isolation and segregation. And there's also an expectation on being able to become neurotypical or to fix. The social disability model is more about saying, hey guys, I'm okay just because I am. I don't have to aspire to something I'm actually not, and I actually can't be. I can't be neurotypical. My brain won't let me be neurotypical. I'm always going to be autistic. I'm always going to be ADHD, and that will always be there for the rest of my life. And you know what? That's okay. It's really okay. It doesn't make me less. It doesn't make me broken. It doesn't make me impaired. What is happening, though, is that at the moment, our society as it is doesn't get that and doesn't get us very well. And I am so hoping we can change this, because we're great. We really are pretty awesome. So the social disability model is talking about the fact that we are disabled because of the social barriers that are in place, not because there's something inherently wrong or bad about who we are. Having said that, again, we have this need to consider the individual, and personally, I don't sit one side or the other. There are some occasions where things are a challenge no matter what society looks like. As a very good friend of mine said, my daughter can be sitting on the beach all alone, nobody around her, with no societal expectations, and still be overwhelmed and still be in a state of panic. So it's about really understanding that while we are valued, there are some things that are just disabled as well. But that's when we have to consider the fact that disability doesn't have to be a bad word. this is a really nuanced area, and I wish I could have spent the whole 2 hours talking about just this. And I am certainly validating that some people are going to land in a space differently to what I do. Mine's a very personal opinion. And it really does depend on each individual. Like personally, I feel that most of the disability I feel is social disability. But I have my limbs, I can talk, I'm intelligent, I'm white, I'm educated. I have all those wonderful things going for me. There are a hell of a lot of people out there that don't have that. And I can't speak for them. So all I'm giving you is my opinion here. And I think that's really important to really highlight. And this is why I keep saying we need to consider each individual. And you'll see every third or fourth slide, I'm going to say we need to sit with the individual. We need to sit with the individual. So I hope that I am making that clear, or muddying the waters a little bit less, shall we say. All right, so the other thing that has changed really recently is the way that the autistic community generally likes to be referred about, and the neurodivergent community. I'm sorry, I keep slipping into autism, but once again, I do mean neurodivergence. There's two different ways of talking about neurodivergence. There's identity first language and person first language. So identity first language is used when the person feels that neurodivergence is actually part of their makeup. So part of who they intrinsically are as a person. And their language uses, I am autistic. So it's sort of like saying, I can't say this cell is autistic, this cell's neurotypical, you know, this cell's and a little bit in between. And so to me, autism is an inherent part of who I am. There's not parts of me that's autistic and parts of me that are neurotypical. That's what identity first language is indicating. The other side of that is the person first language. And that's used when the person feels that neurodiversity does not define who they are. And the language used here is I have autism, or I am on the autism spectrum, or I am ADHD, or I have ADHD. Sorry, not I am, I have ADHD. And the argument there is that I don't want to be seen as my diagnosis. I want to be seen as a person. And I'm a person, just like the next person is a person, and I'm valued just like the next person is valued. I just happen to have a neurodivergence as well. So you can see how both sides are, again, very, very valid. So, and this is a little bit of a visual that might help explain sort of the difference between identity first and people first language. So the first three are considered person first language, suffers from autism, on the spectrum, or person with autism. And then the last one, the autistic person, is identity first language. When I find a term for identity first ADHD, I will let you know. That's a tricky one. I tend to say I'm an ADHDer. Grammar's all off with it though. So, you know, go figure. So when we actually have done some studies into what people actually prefer, as a whole community, the vast majority of people prefer identity first language, something like 70 to 80%. If you ask the person with the neurodivergence. If you ask parents or health professionals, they tend to use person first language. And health professionals particularly still seem to be a little bit stuck on person first language, and they say that's a scientific model and that's what we should use. However, I am noticing in journal articles recently it is starting to switch over. So what we are generally saying is, if you're talking about the community, or if you don't know and you cannot ask the individual, we assume identity first language, because 80% of the time you're going to get it right. If you're speaking to an individual, just ask them and then honour their answer. It's the same as gender. Ask what pronouns to use. If they say they, them, use they, them. If they say he, she, use he, she. Same thing. So it's, again, one of those things that we now have a clear majority in the community, but there are some people who do prefer the opposite way. There's no right or wrong way. It's definitely just a preference. Alrighty. All right, masking. The problem I have with masking, not as a concept, is the word, because often I will say to somebody, sometimes it's difficult to identify females on the spectrum because they're really good at masking. And it's a generalization, but we do see it as a generalization. And sometimes what I get back is like, everybody's a little bit autistic, but everybody masks. And they're right. People do put on different social personas for different environmental conditions. That is very different to the masking that I'm talking about here. The masking that we're talking about here is where a person with neurodivergent has to work very, very hard at actually pretending to be something that they're not, and that is neurotypical. So for me, my natural conversational style is perfectly suited right now because I get to info dump. I love talking about my special interest. Guess what my special interest is? Autism. I get to talk for 2 hours about autism and nobody gets to interrupt me. And this is amazing. This ain't going to work at a party. It's not going to work at a cocktail party. You need to have reciprocal conversation to be able to talk with neurotypical successfully. And for me to actually work that and remember to stop talking, and to remember to show interest in the other person, and to remember to make eye contact, and to remember to have my body language centered on the person I'm talking to, and to remember to track 3 or 4 conversations at once. All of those are very difficult for me. And I can do it for about 3 hours, and then I exhaust. If I'm forced to do that 9 to 5, Monday to Friday in my regular job, you can imagine what happens. Burnout, stress, anxiety, depression, because I'm sitting here going, but this isn't me. This isn't who I am. This isn't what I do. So masking is when I'm talking about masking here, I'm talking about the type of masking that is actually very effortful and is actually harmful to the individual, because as it says, it requires immense cognitive or thinking effort. And it's usually, again, because we have been educated and situated as a society that neurotypical is the goal, the aim, the superior. And it's just not, you know, it's just not. We're just different. So like I suppose I'm relatively masked now. I think I'm becoming more unmasked as the time goes on, but oh well, we'll work this out. So okay, and we've got to have a giggle halfway through, don't we? So There's for a person going out in our lovely COVID world at the moment. Don't forget your mask, and there's the other mask. I often find masking, especially when I'm assessing females, can really cloud the issue as well, because often I'll get the parents saying, "Oh my God, they're having multiple meltdowns a day, they're aggressive, they're defiant, they're not compliant, they're info dumping, they've got a lot of sensory challenges, they're doing this, they're doing that." And then I talk to the school, and the school goes, "They're fine. We don't see any problems at all. They sit in class, they concentrate, they do their work, they're quite bright, they've got friends, they're fine." And what we're actually seeing is that child is masking really hard at school. And then they're getting home and they're going, "Oh, thank God I don't have to mask anymore." And they're exhausted. And you know, every person, neurotypical to neurodivergent and everybody in between, if you're exhausted, you don't emotionally regulate very well. You become grumpy, you become short, you become tetchy. And so a child with autism who might have interoception problems, so might find recognizing body clues to how they're feeling already quite challenging, and is then exhausted as well, they're going to melt down. They're going to have that panic attack on steroids, which is what I call a meltdown. They're going to be defiant because they don't have enough energy to do any more tasks. They need to fill their cup again. And a social cup, of course, tends to be, neurotypical social cup tends to be a lot smaller than a neurotypical's would be. So, interestingly, there's been quite a few autistics say they like wearing masks because they can make all the funny facial expressions that they think about when we talk to neurotypicals, and nobody knows why. Anyway, so the final one, I think this is the final one, I get lost in my slides, is ableism. So ableism is a form of discrimination, and it's a social prejudice against people with disabilities or people who are perceived to be disabled. And this is where we're assuming that neurotypicality is the superior and the better and the desired state of being. And again, it relates back to that, you know, social disability paradigm. We're in a neurotypical world. We have lots of barriers to society, and because we've got those barriers, we are exhibiting as somebody who is struggling or somebody who is challenged, and therefore we're seen as less than, and away it goes. Ableism also refers to the assumption that we want to be neurotypical, and the assumption that we can be if we just tried a little bit harder. Everybody tells me one more time, well, if you just write a to-do list. ADHDs don't think linearly, which is what a to-do list is. We think curvilinear, like we think mind map and random associations. You can't write a to-do list for that. And this is why we can't do to-do lists. Sometimes we can for 2 or 3 months, and then it all falls apart because it's a form of masking. But I always laugh when they say, just do a to-do list. Where do you think I would have if I could have before, you know, coming up on 50? Anyway, so these are just some examples of ableism. Everybody is a little bit autistic. Sure, just like everybody can be a little bit pregnant. Everybody can display neurodivergent traits. Absolutely, absolutely. But being neurodivergent is a brain structure difference. And so, you know, I can be a little bit neurotypical if I want to, but I'm masking. Another form of ableism is assuming that if you're non-speaking, which is what the community prefers to non-verbal, it also assumes and correlates that with intellectual impairment. That's not the case. talking ability, expressive language, has nothing to do with cognitive ability. They're two very separate things, and they need to be seen as very separate things. Assuming a lack of capacity due to asking for reasonable accommodations. This is something that I think was a really big aha moment for me very recently. I've just, late last year, as I said, been diagnosed with ADHD, and I was put on stimulant medication. I had not realised that for most of my life, I felt simultaneously very smart and very dumb, because I know I have a superior IQ. I've been told my whole life I'm gifted. But do you think I could display that? Do you think I could actually get that out? Do you think I could actually write a report from start to finish without getting out of my chair a million times? The reason why I'm sitting here for this long right now is because I have my stimulant medication on board. To have somebody look at me unmedicated would to be seeing somebody who is clumsy, disorganized, scatty, all over the shop, messy. But that doesn't mean that I'm not intelligent, and it doesn't mean I don't have capacity to actually really perform quite well if I'm given the right accommodations. So things like, I saw an amazing meme on Facebook the other day, and it was a teacher, and it said, if a child fails a test, of course I'm going to let them resit it. Because why would I just say you fail and then expect you to just deal with that? Part of the test is the learning process, and failing a test doesn't make you not able. It just means that you can't sit test conditions. So when we talk about asking for accommodations with children, we actually talk about assessing in different ways. So we talk about if it's a verbal presentation and a child has selective mutism due to severe anxiety, don't get them to present verbally, get them to present written, or get them to record it at home in a safe environment and show it to the class, or get them to write a report instead. Because we're assessing the knowledge of the topic. We're not assessing their ability to verbally prevent. Why get them to handwrite if you're not assessing handwriting? Who's assessing handwriting nowadays anyway? Who still actually handwrites anything? I don't know. Another way of being ableist is to expect the neurodivergent person to make all the moves or to do all of the masking. What we're asking now is please meet us in the middle, and I'll talk about the double empathy paradigm a little bit later on around that. And also to expect the neurodivergent person to want to be neurotypical. And so somebody just said they adore handwriting. Cool. I'm really glad there are people out there. I go through fits and starts, but anyway. So there's also that concept of internalized ableism. And that's one of the most damaging things to our mental health, is when somebody who is neurodivergent actually sits there and denigrates themselves because they're not performing to neurotypical expectations. And I did for many, many, many years before I was diagnosed. I'd sit there and I'd go, why is it that everybody else can work 9 to 5, then go out for drinks with their mates later, and then get up the next day and still work 9 to 5? When I have to come home after 5 o'clock, I'm nearly asleep on the couch, and don't you dare ask me to go anywhere because I'll panic. There must be something wrong with me that I'm tired all the time. There must be something wrong with me that I have to sleep all day Saturday to catch up from the week's work and can only get one day on a Sunday, to do stuff. I must be lazy. I must be not good enough. And that's internalized ableism, because I'm just fine. It's just that in this neurotypical world where we're busy, 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 busy all the time, it doesn't suit my brain. And this is where I love running the business that I do, that I've now got it to the point where I only have to be in the office 2 or 3 days a week. And it's so much suiting my brain so much better. And I'm working so much better. So why neurodiverse affirmative practice then? And I hope I sort of already answered this a little bit now. But one of the reasons is we now have adult neurodivergent people that can tell us their stories. And we sort of throw around this phrase, nothing about us without us. And that's really, really important. Until recently, we didn't have those adult voices saying this is what it was like for kids growing up in a neurotypical world. This is how hurtful it was. This is how hard it was. This is what we do want. This is who we are. Please see us as individuals. And what they're telling us is something very different to what we've been assuming before. I'm going to break in a minute. I'll probably break after this slide. I've just realised I've been talking so long. There's increasing and strong evidence of traditional interventions causing harm. I will go through that in a little bit. And neurodivergent people, we don't need to be fixed. Please don't fix us. We don't want to be fixed. Please don't fix us. All right. I'll just click through. Okay. I've been speaking for 50 minutes already. Why don't we take a 5-minute break here? Okay. So where were we at? We're talking about why neurodiverse affirmative practice. So, and we're saying that, yep, we've now got adults that can tell us what's going on. We are seeing increasing and strong evidence of traditional interventions causing harm. And we're saying that neurodivergents do not need to be fixed because there's nothing wrong with us. Okay, so let's have a look at this evidence for harm. The biggest and most populist therapy modality, and I don't want to go into this a lot because I don't want to be too denigrative. I really want to keep this a positive space if I can. Anyway, the most popular therapy is applied behaviour analysis, or ABA. And again, I could spend 3 hours on why I don't like ABA, but I'll keep it short. So ABA was introduced as a therapy many moons ago, and it's based on basically behavioralism and behavioralism only. And it aims to teach neurodivergents how to become more neurotypical, basically. There's lots of arguments around how the new ABA is more ND affirmative than the old ABA and how we've gotten better at things. And I could give you a whole lot of stuff that demonstrates that I don't feel that's true. But again, this is not the place for that. So I'm not going to go there with that. However, we're doing more and more literature and research into how effective ABA is. And the most recent meta-analysis that the CDC in America has validated, I think it was CDC, or was it Department of General Surgeons, or I can't quite remember, nerves, show that there's no overall positive gain in autistics. What they mean by positive gain, well, you know, that's a whole other story. So, and there are some studies that are now showing that autistics that have undergone ABA have higher rates of PTSD than those that haven't. There is a rider on that though, in that the studies that have shown that are not robust at the moment. I do believe it's a true result personally, but we haven't got the robust studies to really show that. So there is that rider that while there's indications there, if you're going to just rely on research-based evidence, it's a little bit shaky at the moment. So the research also shows that the good outcomes that they talk about ABA produces great outcomes, and these kids end up being not autistic. The Sunrise program is another one that claims, and the Early Start Denver model say, we can make your child be not autistic anymore. I've just spent the last hour saying, please don't fix us and make us not autistic. We don't want to be that way. But anyway, that those outcomes tend to be based on neurotypical behaviour gains. So those outcomes will be measuring things like ability to sit still, ability to make eye contact, ability to follow 2 and 3 step instructions. What they're not measuring, though, is the mental health gain, loss, or change in these people. And more and more and more and more, we're seeing autistic adults who have gone through ABA say, I am now traumatized and I don't ever want anybody else to be traumatized the way I was. I was forced to do stuff. Yes, I can do it because ABA taught me, but it causes me distress. We have to listen to those voices because they're the ones that lived it. They're the ones that did that. And I've completely lost my train of thought. I hate it when that happens. So I think it's really, really important to consider that these early intervention studies were all around trying to get somebody to be more neurotypical. I just saw a question pop up. I can answer this right now. ABA is applied behavioural analysis. And so there are some parts of ABA that are practiced. There are some parts of practice that ABA uses that aren't ABA specific, and one of those is positive behaviour support plans and functional behaviour analysis. And I am going to go through a little bit later how to do those in a neurodiverse affirmative way, because sometimes they're necessary. So the other thing that we need to consider is that neurodiverse affirmative practice isn't a modality. It's not a therapeutic modality. It's not like, hey, I'm going to do CBT. I'm going to do neurodiverse affirmative practice. What it is a conceptualization and a way of thinking and a way of being. And so we can actually adjust any current therapeutic modality to be neurodiverse affirmative, and that's what I'm about to talk about, is how does that actually look. So, and I think this is the power in this paradigm, is I'm not going to teach you a new way, I'm not going to teach you a new modality like schema therapy. I'm going to talk about how you can bring a whole new attitude and a whole new way of thinking into what you already do so well as a therapist. Because I know some of you are brilliant schema therapists, some of you are brilliant psychoanalysts, some of you are brilliant CBT practitioners, some of you are brilliant ACT practitioners. Some of you are eclectic, like a lot of us are, and like I am myself. But we can make any of that neurodiverse affirmative, and that's the strength of this. ABA is very much a modality. Early Start Denver model is a modality. Sunrise program is a modality. Alrighty. So when we're talking about neurodiverse affirmative practice, what do ND voices say? Consult us. Lived experience is much more valuable than book learning. You can read 1 million books on autism. You're still not going to know it until you work with it. You're not going to know it until you sit down and talk to us. And because this paradigm is so new, it's going to be very difficult to find printed literature about it. It's absolutely out there. It's absolutely out there, but it's not generally in peer-reviewed literature. At the moment, it tends to be in podcasts, YouTube channels, blogs, autobiographical books, etc. So, for example, I'm currently reading a bit of an autobiography, The Neurodivergent Mind. I quite like this one, actually. I'm quite enjoying it. It's not a textbook. It's not a peer-reviewed article. It's not literature. I'm hoping that this is all going to come. Okay. What else do we say? How many times have I said this? We don't want to be fixed. We're not broken. We're born this way, and we're actually a valuable part of society. And you know what? Sometimes, often, the way our brains work can bring a richness and a different perspective to things that can cause our society to progress in ways that it would never have done if neurodivergence weren't part of us. So, and again, don't expect us to aim for neurotypical or even want to aim for neurotypical, because it damages us. It really does. It would be like asking a neurotypical to act autistic all of the time, 24/7. Show me a neurotypical is going to turn around and go, yeah, sure, I want to do that. That's fabulous. Because they don't. So learn about some of the myths that are out there and try and meet us halfway. I'm pretty sure I've got a slide on myths coming up next too. And learn and be aware about ableism and reflect on your own experiences and your own concepts around that. And I'm the first person to say that I am not perfect in that, and I still slip up, and I'm still ableist at times, and I can still slip into non-affirming language at times. And I think it's really important to, if anybody has done circle of security or attachment type therapy, it's not about the rupture, it's about the repair. So we're not going to get it perfect all the time. We're not going to get it right all the time. That's fine, but own it when you don't. Don't try and defend yourself and make excuses. So yeah, I got it wrong. Sorry, guys. I'll try again next time. All right. When in doubt, ask us, please. The number of times when I do consultative supervision, you know, like that one-off stuff. I've got a client, but I don't know what to do with them. Type supervision. The therapist will describe the client to me, and we'll be talking about the case. And they go, "What do you think's going on? What do you think I need to do here?" And I said, "Well, have you asked them? Have you asked them what they want? Have you asked them where they're going?" And they go, "No." Well, why not? Oh, ask us. It's really easy. We tend to have the answer. Especially with children. Again and again and again, we assume that children don't know what they want and what they're after. You'd be surprised how good kids are at letting you know what they're on about. Yeah, Alex, you're dead right. But as I said, not time to go into that now. There's a really good comment, and I think it was made by Deb Dana. I can't remember. I think it might be. Anyway, this person said that a child is an expert of making you feel what they are feeling. And I love that. So if you're in a session and you're feeling really frustrated, Dan Tootin, it is the child is also feeling really frustrated. And it's about, you know, stopping, listening to that, doing what you can to feel comfortable again, because that helps the child feel comfortable again. And that's all nonverbal communication. So ask and note in the language that's going on. So this is a bit that I hope to get through before the break. So I hope I don't end up running late. Okay, so then what is ND affirmative practice? And the reason why I've put some question marks here is that there is no one succinct sentence and there's no one statement. It is lots of different things and it's lots of different behaviours. But what it contains is it is client-centred, and it is also always client-centred. Now, every good psychologist, every good therapist, every good allied health practitioner, every good medical person should be client-centred. It's what we're taught and it's what we should do, but we forget it. And we forget it all the time. being mindful about being ND affirmative reminds us all the time it's about the client and about what the client wants. And sometimes what they want can be really distressing for the therapist to hear. Tough. It's got to be client-centered. Non-judgmental is another one. You can't bring your own stuff into the therapeutic place. I mean, you have your lived experience which helps you understand, but you cannot overlay your beliefs and your judgments and your values onto your client. That's not the space for it. Not in the therapy room. ND affirmative practice assumes competence, and I'm going to clarify that, because if you go, oh, we assume competence, that can sometimes be construed as meaning I'm going to assume somebody in a wheelchair can walk, and that's not what I mean. What I'm talking about is things like not assuming intellectual disability for somebody who is non-speaking. Assuming that if given the opportunity, a person can communicate in one way or another their needs. So it's about going in with a very open mind and asking and sitting with the person and getting to know them and not assuming. We don't treat the neurodivergence. So at Left of Centre, my clinic, we very proudly say we don't treat autism. We don't treat ADHD. We don't treat gender diversity. What we do is we support the person to lean into their authentic self, to discover who they really are, to advocate for themselves in a generally intolerant neurotypical society, and to help them build strategies for the mental health correlates that come from being neurodivergent in a neurotypical society. That's what we do. It is, of course, respectful. It is, of course, it honours lived experience and neurodivergent voices. And it does not align neurotypical as ideal, as superior, or as the best. Just different. That's all. So, to me, that's what neurodiverse affirmative practice is. That I don't claim that this is set in stone, and I don't claim that this is a universally accepted paradigm because it's so new. This is my idea of what it is. And if anybody wants to add to this or discuss it, please join one of the neurodiverse affirmative groups on Facebook or LinkedIn or Twitter or whatever, and start to talk about it. Because the more it's talked about it, the more it's going to be refined. And the better we're going to get at this. Okay, so some elements to consider when we're talking about this is we have to always be aware and identify and address ableist attitudes and behaviours. And that's about really catching yourself when you say things like, oh, Jesus, I can never stop them talking. I wish they'd just, shut up and listen someday. Well, autistics tend to infodump. Maybe it's okay for you to shut up and listen to them. That's just an example. And some other elements to consider is to focus on the strengths and the area of client-identified supports. Again, client-centered. Where does the client say that they need supports? Help build self-advocacy skills, and within that, definitely assertiveness skills. I teach assertiveness to almost any client that walks in the door. It's a beautiful lifelong skill. Supporting the modification of the environments. So again, when we talk about modifying environments, we are actually leaning into the social disability paradigm, and to explore the authentic self. What does it mean to be you? And if you could be you with no expectations of behaviour, with no societal demands, what does that look like? And we all know we're not always going to get all the way there, but it's quite amazing when you get close. It's quite freeing when you get close. Okay, so what it isn't, as I said before, it's not a manualised program. It's not a modality. Any therapeutic can be in the affirmative. And I have mentioned here, keep in mind informed consent. So there are times when a person's going to say, no, EMDR is not going to work for me. I have anaphasia, inability to visualize, and it's not going to work for me. Or I've tried meditation and mindfulness, and nah, it's not going to work. Interestingly, a lot of autistics find meditation actually worse, because we tend to overthink anyway. We don't need to sit in our mind any more than what we already do. It also isn't fanaticism. And with any new paradigm and with any new movement, there's always a fanatic element. And I think it's really important to validate that those people are obviously very passionate about what they're talking about, but also recognize that it is just their own opinion. So I have a number of clients who will walk into the room and they're going to say to me, my goal of therapy is to learn how to mask. I know damn well that that's going to cause them mental health challenges down the line. I would love to be able to say, please don't, because you're doing the ND community a disservice, but that's not for me to say. If that's their goal, and I have to sit with that, and I have to support them in that, and I have to do that authentically and genuinely. Again, coming back to being client-centered. So if they feel that for their well-being, masking is where it's at, that's what we do. It also isn't a fixed paradigm. We're always learning, we're always refining, as society is going to, and it will definitely become more neurodiverse affirmative. Things are going to change. As we get to know more about what it means to be neurodiverse affirmative, it's going to change. And if we try and fix something, what we're going to do very quickly is date and become outdated. We have to keep flexible, and we have to keep reviewing and refining and learning. All right, so my lovely friend Erin from Sanson and Bullis Psych actually had a bit of a rewrite of the DSM-5 autistic criteria, and I just love it. So I've just put it here as well. And she has very beautifully taken away the deficit language and put in the difference language, which I love. So instead of persistent deficits in social communication, it's differences. And instead of restricted and or repetitive patterns of behaviour, it's niche, idiosyncratic and predictable patterns of behaviour. And I love this because it does really talk about a difference model. All right. So what is needed to be neurodiverse affirmative? I feel like I'm starting to repeat myself. You're probably getting a bit sick of me saying this. Non-judgmental, client-centered, monitoring automatic ableism. But we also need a really good understanding of what neurodivergent individuals look like. And of course, ideally, the best way is if you're neurodivergent themselves. But guess what? We're in a minority. So if you aren't neurodivergent, if you're neurotypical, you can still learn this stuff, and that's cool. We might accept you at some point. No, I'm joking. I'm sorry. So get to know the core traits of the population that you're working with, and you decide to work with autistics or ADHDs or gender diverses or dyslexics or whatever. So get to know that really, really well. And there are textbooks traits, and there are DSM criteria traits, and then there are the nuanced traits. And those nuanced traits you're only going to know by talking to neurodivergent people. Get to know their communication style And I'm going to go through in a minute this thing that we call the double empathy paradigm or double empathy problem. And they're the two that I'm only really going to pull out from this list to explain. Understand this concept of monotropism, which special interest is another word for it, but also understand that somebody can dive into a special interest and dive back out, and then dive into another special interest and then dive back out again. But a lot of neurodivergent people do tend to deep dive into topics and don't like to keep it at the surface. They do like to keep it at they do like to deep dive and get really, really good at one topic. Most of us will do bottom-up processing, so we'll notice a lot of detail and then create a theory out of that detail. They'll notice some patterns and some coincidences and then put it together. Most neurotypicals, top-down process. They'll see an overall structure and then they'll look for the details that confirm that structure. Again, generalized, and again, there's exceptions to that. And have an understanding of what we call the intense world theory. Our neurology means that we often feel the world much more intensely than a neurotypical. Hence, we often have a huge sensory profile. We tend to experience trauma a lot more quickly over smaller adverse events. We tend to react emotionally more strongly to things. And so we feel the world intensely, and it can cause things, and I'm sure some of you have heard of autistic burnout, because we're in it, and we're all the way in it, and it can hurt sometimes. So you know, be very aware of that as well. The two things that I'm going to pull out of here are the communication style and the double empathy paradigm. So the communication style, neurodivergents may be more literal. They may not like social chit chat. They may not want to use eye contact. They may perseverate on preferred topic, special interest, info dump. Very commonly, stress, overwhelm, or anxiety may render verbal communication impossible. Excuse me, and that's the idea of that selective mutism that sits there. And they may prefer to not use or not understand sarcasm, irony, idioms, or innuendo. Says me, who's a highly sarcastic person. So, you know, generalized. The other thing, have I mentioned it here? Sorry, I'm just going to click through. No. Okay. The other thing that I've only just started to notice recently, and I've just started talking to some colleagues recently, is that we actually show empathy often by sharing our own narrative. So when I was taught counselling, the counselling course in my psychology degree, we were taught to show empathy by reframing and by reflecting. So it sounds like you feel really angry about what happened to you. To somebody who's neurodivergent, often they'll say, that doesn't sound authentic. It doesn't sound like you really get me. But if I was to sit here and say, yeah, I remember a time when that happened to me, and I remember that it felt really like this and that, and I did this and that, and somebody will say, yeah, now you get me. Now you know where I'm at. And that story, that narrative relating empathy is actually more aligned with the Aboriginal way of relating than to a white European way of relating. So, you know. Okay, so this was a study done on autistic adults' view of the communication skills and needs. I'm not going to go into it a lot. I am aware of time. But basically, we're looking at things like anxiety will always exacerbate communication difficulties. We will tend to lose our verbal skills when we're anxious. Or we might still have verbal skills, We might be able to talk, but our ability to articulate may be lost. The environment, the communicative environment, can be very overwhelming. Talking in a group can be much more difficult than talking one-on-one. Talking with a lot of background noise can be very difficult. And the communication partner can make a difference. And there's some really nice research about 2 different ways of communicating, and I can't remember them at the moment. I am so sorry. But if you've got a communication partner who communicates in the way you do, it's going to run much more smoothly. And the other things that I want to pull out of this graphic is that when we're not understood and when we're not allowed to communicate in our own way, we tend to withdraw then from society. And we can actually have some mental health correlates around that. So it's actually really important to try and meet the communication style. And the reason why I'm talking about communication specifically as therapists, where, you know, we're talk-based therapy. So it's very important that we get this talk-based stuff right. All right, let's go into the double empathy paradigm. I love this. I love this. It used to be said that, and still is a lot, that neurodivergents have deficits in social communication. We now know that's BS. I'll try not to swear too much, I'm sorry. What we do know is that we are quite able to communicate very effectively with our own kind. So, and there was a lovely experiment done called, I don't know, I'm just sure you probably all played it in primary school, called Chinese Whispers. And it's where you're given a story and you have to whisper it into the person's ear next to them, and then they have to pass the message on, and then they have to pass the message around. By the time it comes back, it's a completely different message. Where they performed this study with 3 different groups. A group where there were only autistics in the group, a groups where there were only neurotypicals, and then a mixed chain where there's an autistic, non-autistic, autistic, non-autistic down the line. Guess what? The autistic chain and the non-autistic chain had the same outcomes as the mixed chain. And I'm pretty sure, there we go, I've got it on the next slide. So you can see that if you've got an autistic speaking to an autistic, we can do it real well. We're just fine. Just as good as neurotypicals, and it really debunks the idea that we have social communicative deficits. We just have social communicative differences. But if you're trying to talk across the 2 neurotypes, that's when the problem comes in. So, and this is when we're saying, please meet us halfway. Because if we can make the effort to try and relate the way neurotypicals want to, why can't neurotypicals move a little bit and try and relate in the way that neurodivergents want to? And somewhere in the middle, we might get a meeting of minds and we might get some understanding. Please, please. Okay, so what does neurodiverse affirmative look like in session? How do you know you've got a neurodiverse affirmative therapist, and how can you become a neurodiverse affirmative? Again, client-centered goals, client-centered goals. So we ask, and there are lots of different ways. You know, sometimes we often have clients walk into the room and they don't know what their goals are, and there's lots of different ways we can actually get those goals clarified. We don't look to treat the diagnosis. As I said, at Left of Centre, we don't treat the neurodivergence. We support the exploration of it, and we help treat the mental health correlates that come off it. What I find quite important is to allow orientation to the environment, the therapy process, and the therapeutic relationship. This can take significant time. And it can be 4, 5, 6 sessions time, not 10 minutes, but you know, a number of sessions. And allow for preferences. So I will make sure that my waiting room is always set up in the same way. I'll make sure I let some of my clients I need to very much let know if I've rearranged my therapy room. Those type of things. I will very much allow the relationship to grow very slowly and organically, and I will not try and push that in any way. It's really, 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 really important to be honest and authentic. There's a term that's very common in the neurodivergent world called being an empath or being a highly sensitive person. And what that basically is that it's that whole intense world model. We actually detect emotional energy and authenticity almost instinctually in a way. And I don't know how else to describe that. And I'd love there to be some actual research around that to try and, tease that apart. But absolutely dead certain, if you're not authentic, a neurodivergent person will pick up on that and you've lost that relationship. And you often can't repair that relationship. It's often done. So be authentic, be honest. Honour the client's communication style. And even if that means an explicit conversation about how it's going to work, that's fine. So if they need to come in and for the first 20 minutes they need to info dump, that's fine. Let them do it. If they need to, I have a number of clients in session that we will be in session face to face, but we will text each other. Or they will write out or type out the question and I'll answer verbally. Or they will, I used to have one client, the only way they could verbally talk to me is if their back was to me. That was fine. I don't need eye contact. I just need to know that they're getting some benefit of the session. And then ask how they prefer to receive information. I often, like I've said before, you give me something verbally, I ain't going to remember it. A lot of neurodivergents are the same. So I tend to actually write up a quick summary of the session and give them what I call their cheat sheet at the end of the day. Some people will take notes in session. Some people will record my sessions. Some people will ask for a summary email at the end of the session. Some people, as I said, we would prefer to text during the session or whatever. Again, just ask how that works for them, how that therapy is going to sort of embed into their brain in the most effective way, and honour that as much as you can. I love your comment, Vika. Okay, so don't expect eye contact. Often for a neurodivergent, being forced to meet eye contact is as uncomfortable as asking a neurotypical not to meet eye contact. It can actually take, it can actually be painful, and it can actually take so much energy that you can lose focus and concentration on the actual conversation. So don't expect eye contact. Allow and welcome sensory items. They can either bring their own or you can have some that are provided. Allow and welcome different seating styles. You can sit on the floor. You can sit on the beanbag. You can sit on the couch upside down. I don't care. I've already talked about the different communication style. I tend to keep sensory input low and then let the client determine if they need any more sensory input. And I'm also flexible with session length. Sometimes half an hour is all an ADHD can take. Sometimes there's so much info dumping, I have to allow 2 hours in a session. So it's, again, asking the client how it works best for them and trying to be as flexible as you can. Okay, so for kids, I'm really big on listening to the child rather than the parent. It's one thing for the parent to come in and go, I need them to sit still at dinner because it's really annoying and it disrupts the family. Absolutely, it's really annoying and disrupts the family, but that child's not going to eat if you're going to force them to sit still. It just ain't going to happen. So, but of course, because the parent's paying for the session, it becomes that little bit of that dance and a little bit of that finding that middle ground. So I do very much goal what child does, but then I advocate for the child with the parent around meeting those goals. Also ask if any accommodations need to be provided. I ask both the child and the parent. Sometimes the child isn't aware. Do they need headphones? Do we need to turn the lights off? Do they need to have some moulding party, whatever there are. Meet them where they are at. Drop down your verbals, sit on the floor with them, all that type of stuff. Use the special interest to engage. The one almost guaranteed way to get a child to start to talk to you is to talk about what they're interested in. So I know lots and lots and lots about Harry Potter, about Minecraft, about Pokemon, about Yu-Gi-Oh, about all the types of things. I sometimes I swear that a love of Minecraft has to be a diagnostic criteria. So can't stand the game myself, but I know lots about it. Please don't use token economies. They're not monkeys or dogs to be trained, and the research actually shows that using token economies actually decreases intrinsic motivation. So star charts, reward charts, they just don't work. I always do parent training and parent support around what it is to be neurodivergent. And what I often find is I get a real shift in the way the parents look at their child from a punitive, they're disrespectful, they're naughty, they're bad, to they're just distressed, they're just struggling. And once I can get that shift, we get a much better dyad relationship going on there. But also recognise that therapy will often be much slower. And that's usually because we have to go back and teach interoception, also the ability to read your body, to be able to understand what emotional state you're in. So with adults, where I'm usually extra sensitive regarding the therapeutic modality. And when I talk about that, there is some research that, as I said before, things like meditation aids are great, so a lot of mindfulness stuff doesn't work. EMDR can be problematic. So again, a very careful discussion around that before you sort of dive in to therapy. Be very, 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 very transparent. And to me, that is about explaining exactly what I think is going to work and exactly what I think is going to happen. And exactly how the process works, exactly how the modality I'm going to use works. And if I can, and get that enthusiastic informed consent, that yes, this is what I want to do. And I check in a lot. I check in and say, are we still going where you want you to go? Are you sort of getting where I'm headed with this? Do you understand? Lots and lots of checking in. I pre-warn of any changes, room layouts. With some people, I actually have to warn them when I change my hair color. I'm not always blue. Sometimes I'm different colors. Even I have one client that I have to send them a photo whenever I get new glasses. I normally wear glasses, but the reflection isn't working tonight. I tend to have a very regulated calendar. Same clients are on the same day at the same time every week. And that seems to be very reassuring for a lot of my clients. And be aware that there's high likely to be trauma, and it's very important to have a good trauma framework to work from. The recent literature is coming out with well over 50% of neurodivergent people also have trauma. Highly sensitive nervous system with an intolerant world creates trauma. This is my therapy room. I love my therapy room. I really do. You can see that I've got a couch, I've got a chair, I've got bean bags. I've actually got in the other corner some cushions that you can see. But these beautiful, beautiful windows I've absolutely lucked out on these rooms means that I can turn the electric lights off and we work in natural light. But if the view is too distracting, of course we can close the blinds if need be. So I can have the blinds closed, the lights off, we can have a dimmer room. I can remove all the cushions because I do actually have on the wall that you can't see is all storage, so I can put all that stuff away and have it stripped down bare if need be. And I have worked on the floor so often, it's not funny. So, but I love my room. It's absolutely fabulous. I'm just thinking, that hasn't changed much since from there. So, okay, very, very briefly, I know we're up against time. Neurodiverse affirmative positive behaviour support. Now, for those who aren't aware, positive behaviour support is basically looking at what do we do when we see a behaviour that we don't want to see. And often the behaviour we don't want to see is a socially inappropriate behaviour. Now remember, that's neurotypical, social appropriate, so we're going to see a lot of it in neurodivergence. So often these PBSs are actually not very neurodiverse affirmative because we're saying to them, you're not acting the way we should. More than the way you should is neurotypical. And I've just spent the last, hour and a half saying that neurotypical is not better. So why should they be doing this? However, there are some times when PBSs are necessary. And it's normally if the behaviour is highly aggressive or violent, or if there is a particular skill that a client does want to learn and the way they're doing it is through a PBS. So I would like to really remind everybody that every single behaviour that anybody performs is communication. And this is where I get a bit annoyed with ABA because they talk about non-communicative behaviour. Doesn't exist. Okay. Again, if in doubt, ask. And always, always, always keep the client's well-being in mind, not the carers. Often PBS is about making the client behave, which makes the carer's job easier. I'm sorry, the carers are paid to do their job. The client is going to be the client, and we have to keep that in mind. When assessing via a functional behaviour analysis, dig deeper than surface function. We're all taught when we do FBA that behaviour tends to be either sensory gain or avoid, task gain or avoid, or attention gain or avoid. That is so surface, it's not funny. We've got to dig a lot deeper. And do not stigmatise attention-seeking behaviour. And of course, always keep it in drafts. Okay, so when I talk about the function of behaviour, up the top in that little hole is defiant, escape, attention-seeking and avoiding. And that's where we normally say, but that's just not what it's all about. We have to dig deeper and we have to go, sorry, PBS is positive behaviour support, Nina. We have to dig deeper and we have to look at things like, is it emotion regulation? Are there learning difficulties pushing it? Is there trauma sitting there? But at the very, very, very bottom, if we keep digging underneath all of that is safety, FBA's functional behaviour analysis. So looking at what triggers a behaviour and what the consequences of the behaviour are. But at the end, at the bottom of all of this behaviour, each and every single behaviour is done because we're looking for safety. We're looking for feeling to be safe, validated and attached. So if we see every behaviour and if we see a behaviour that is distressing the client, we're going, they're not feeling safe. How can we help them feel safe? And that's what a PBS should be. The supports that we put in place to help a client feel safe. If we can keep that in mind, that's when we get good PBS. The other thing about validating attention seeking. Often I'll have teachers say, oh, he's just doing it for attention seeking. And my reply is, and? Give him attention. What's wrong with somebody wanting attention? We all want attention. We all want connection. Even neurodivergence, we want connection. We just want connection with people who get us. Then the connection is enriching. So I love this visual, because it reframes attention seeking into either connection seeking, so see me, hear me, accept me, into attunement seeking, so consider and respond to my needs, organise and validate and hold my feelings, and be curious about what's happening for me. And that's a very attachment, circle of security type paradigm, or into attachment seeking, that protect me, see my stress and the different ways it's being expressed, support me to regulate, help me to feel safe. So if we can look at attention seeking in this way, all of a sudden it doesn't seem so bad. And all of a sudden the stigma gets dropped from it, and we can actually really support the client in getting their base needs met and helping them feel safe. And that's what it's about. And this is regardless of neurodivergence or neurotypicality, this is what it's about, and this is where we should be sitting. And at the very end, this is our next to last slide. When we talk about children being non-compliant, I don't actually believe kids are non-compliant just to be little S's. They're telling you something. Maybe they're non-compliant because maybe they're not feeling safe. Maybe you're not hearing them. Maybe the modality you're using is not working for them. Maybe there's no flexibility in your approach, or you haven't earned their trust, or you're actually not goaling where they're meant to be going, you're hitting the wrong thing, or you're reenacting the oppression, or maybe you're not the best fit for them. As I said, children are really, really good at making you feel what they're feeling. And if you can listen to that, you're halfway there. I have used up nearly all of my time, and I'd really like to thank you guys for joining with me and listening to me. I hope you've gotten some use out of today's slides. And I will hand it over to the question and answer session. Thank you so much. Thank
Hi,
you for
Allison.
all that stuff.
Can you hear me okay?
Yes, yes.
So firstly, I just want to say thank you for an excellent presentation. The feedback we've had in chat has been incredible. So well done. You've done a great job there. We've got a few questions coming here. People, for anybody that doesn't have Twitter or doesn't want to submit a question on Twitter, you can also just add it into the chat as well, and we'll take it from there too. Okay. So the first question we've got here is from Donald, and Donald asks, what is the difference between learned behavior and masking?
That's a really good question. Oh, I think all masking is learned behavior. Not all learned behavior is distressing. I think, you know, we all learn behavior as an infant and as we grow. And it's very much a choice as to whether we want to keep utilising that learned behaviour or not. So how functional it is for us in society. So I would say masking is a subset of learned behaviour, and it's a subset that causes us distress. I hope that clarifies things.
Okay, cool.
Yeah, quick and easy, that one, hey?
The next one is from Christina. Can you share any tips, links, or resources on how we can support neurodivergent family members at home?
Whoa. Do I get another 2 hours to answer that? Neurodivergent individuals at home. So again, so many questions I get asked. I talk about them being depends questions. It really depends on the context. If you live at home on your own, you can unmask and you can do whatever you want. It's fabulous. But if you have to fit in with the neurotypical family members, it becomes about that advocacy and that support. So again, I would just really look at sitting with a client and asking what they need. Resources, there's lots and lots out there, and it's really hard to give you anything specific, because this was sort of much more of an overview type topic. But there are some great websites, one called the Neurodiverse Collective. The Neurodivergent Collective, please My apologies. That is a website that provides podcasts, resources, tips and tricks by neurodivergent individuals, and it's really quite a cool place to go and visit. Lots of stuff on YouTube, lots of stuff on Facebook, neurodivergent. I'm trying to think. Neurodiverse Affirmative Therapists is a Facebook where you can actually join if you're not a therapist as well. The ADHD Whisperer is another great site for those that are looking for ADHD support, because as we know, it's lagging behind in its recognition as well. And Neuroclastic is a great podcast that provides lots of those ideas as well. So just a couple off the top of my head.
Brilliant. Okay, so we've got a couple of questions now about masking. First one's from Ruth. Could ME result from too much masking? And the second one is from Rosa, and Rosa asks, can you wear masks and enjoy them? In other words, is there such thing as a positive mask?
That's interesting. I'm not quite sure what they mean by ME.
Yeah, ME. Ruth, can you clarify what you mean by ME? In the meantime, maybe you want to tackle the one from Rosa about
yes.
the positive masks.
Positive masking. Good question. I don't see why not. I suppose in my mind, it's a little bit like, ME, chronic fatigue syndrome. Yes, I actually feel that long-term masking can cause chronic fatigue. I don't know how much literature there is out about that, but we do know that we get a lot of somatic complaints from masking for too long. Going back to the masking, is there positive masking? It's a little bit like the schema therapy conceptualization, in that schemas by definition are unhelpful. There's no positive schemas. I tend to see masking in the same way. And I think when I was going through the masking slides, I was talking about the fact that if it's positive, it's more just a part of ourselves and a social persona that we put on for that time that doesn't cause distress. Whereas masking is actually pretending to be something that we are not. I am more than happy to be corrected about that. It is, it's one of those changing definitions that's happening. So if you find a mask and it works for you and it makes you feel safe and sane, go for it. That's the base of ND affirmative, isn't it? Go for it if it works.
100%. Next one from Nell. I know you covered this briefly during the presentation, but what are your thoughts on regular meditative practice for the neurodivergent brain? Is this something that should only be done by neurotypicals, or is this something that you think that people that are neurodivergent should engage in?
I'm going to say suck it and see. It's going to work for some, it's not going to work for others. It doesn't work for me at all. I end up in a huge bubbling, overthinking mess. For some people, it can work really well in calming all those racing thoughts. And it can work really well in increasing interoception. And interoception is the ability to be able to read your body cues and your physical cues. But more commonly in neurodivergent individuals than in neurotypicals, it can actually cause more distress. In a generalization, neurodivergents tend to spend more time overthinking and ruminating. And if you're going to sit still and move into yourself, that's going to exacerbate all of that. So sometimes actually the answer for us is to get out of our own heads. So, again, generalizations. So it's give it a go. If it works for you, fabulous. If it doesn't, damn, let's find something else. So.
Cool. Okay, so we've got a question from Roy. So Roy says he loved your presentation, and that his question is, how do we educate the greater population to take on board your ideas? perhaps he says Me Too and neurodiverse, dyslexic lives matter, etc., etc. He's a dyslexic father with 2 dyslexic children. So basically he's saying today you're speaking to a sympathetic audience who, you know, everyone here is very receptive to your ideas, but how do we, you know, get this to more of the general population, if that makes sense?
Yeah, perfect, beautiful, amazing question. I tend to personally align where we're at the moment is a little bit like the gay movement was back in the 80s. You know, lots of people that, you know, lots of preaching to the choir, having a lot of pushback from those that weren't on board yet. We are certainly still getting a hell of a lot of pushback from ABA practitioners and from people who still see us as a medical and deficit model. I find that it's really, really, really important to not be combative and to not be fanatic, because that turns people off very quickly. So what I tend to do is I'm actually quite active on Facebook, on quite a few forums, and because of my age, Facebook is where I'm at, because if you give me TikTok, I have no idea what's going on. But what I tend to do is, instead of saying you are wrong, I'll say, have you considered this instead? And if you give them options to try instead, and we know this from teaching children and from looking at supports for children, if we give them and try this instead, you're much more likely to change minds and change behaviour than just saying don't do that anymore. Mm-hmm. So it's about very gently, very courteously, and very positively, just tapping back and tapping back and tapping back and tapping back. But please only do it when you have spoons, when you have energy, because it can be exhausting and you can often get a lot of backlash. It can be personal. So you do have to be a bit strong.
Well, that's a great answer, Alison. I think that's all we've got time for today. I want to say thank you again so much for a great presentation. Just before you go, is there anywhere you'd like to send people online? On your website, it's is it loctherapies.com? Is that right? Or
yes, LOC Therapies, as of left of centre, therapies.com. I also have a Facebook page, LOC Therapies. And that's probably a little more active. I tend to post up when I see something really interesting. I'm always available through the Facebook page on Messenger. So if you ever want to reach out, I love to have a chat. So it's all good. I'm also available for supervision or consultation at any time as well. So you can just contact me through there as well.
Great stuff, Alison. Well, thank you so much. Everybody else, we're going to be back. We'll be back at 1 o'clock for our second talk today on neurodiversity and optimal learning. So I'll see you guys all then, and thanks again for tuning in.
Thanks, guys. Thanks for joining us.